Okay, let's unpack this. I am sitting here, and I have to admit, the anxiety is, it's real. The MD exams are looming on the horizon literally next week, and I've been staring at the syllabus, specifically the neonatal section, and it just feels like looking up at Mount Everest without oxygen. There is just so much ground to cover. I feel like I need a lifeline. I need to get into the head of a Gujarat University examiner. So I have brought in the big guns. Sitting across from me is my favorite senior faculty, the expert who has seen it all, quizzed it all, and, well, failed students who didn't know it all. Welcome.
It is a pleasure to be here. And listen, take a deep breath. That tachycardia you're feeling, that's just your sympathetic nervous system telling you this matters. And it does matter. Yeah. But we're going to break it down. You mentioned the neonatal section. That's broad. But in the Gujarat University exams, there is a distinct pattern. There is a holy trinity of neonatal challenges that appears again and again.
The Holy Trinity. I like that. It sounds ominous but structured. What are we talking about?
We're talking about anorectal malformations, or ARM. We were talking about respiratory distress syndrome, RDS.
Okay.
And we were talking about retinopathy of prematurity, ROP. If you master these three, you don't just pass. You look like a consultant in the making. These topics are pillars because they test everything: anatomy, embryology, physiology, and pharmacology.
That is the goal. But here's my worry. I can memorize the textbook definition of RDS. I can list the types of ARM. But when I get into the exam, I feel like they are looking for something else, something deeper. I don't want to sound like I'm just reading off a slide.
You've hit the nail on the head. In our exams, especially at the MD level, we're not looking for a parrot. We're looking for NICU-oriented thinking.
NICU-oriented thinking, that's a phrase I've heard you use before. Break that down for me. What does that actually look like for an anesthesiologist?
It means you realize that a neonate is not just a small adult. It's not even a small child. It is a completely distinct physiological entity. It means understanding that when you intubate a 1.2 kilogram baby, you aren't just securing an airway. You're interacting with a transitional circulation. You are dealing with immature kidneys that can't handle sodium, a liver that doesn't metabolize drugs the same way, and a brain that is incredibly fragile. NICU-oriented thinking means you are the perioperative physician. You care about the glucose, the temperature, the calcium, the sepsis risk, not just the MAC value of your Seville's rein.
Okay. That really shifts the perspective. It's about the holistic management, not just the procedure.
Exactly. The neonatal period, the first 28 days of life, is the most hazardous time of human existence. The margin for error is, it's effectively zero. In an adult, you can make a small mistake with fluids or ventilation and their physiology compensates.
Sure.
In a neonate, you make a small mistake and you are in a crisis. So today, we aren't just going to recite lists. We're going to connect the embryology, which usually scares people, directly to the anesthesia machine. We are going to see why a folding error in week 4 of gestation changes how you set your ventilator in week 36.
I love that roadmap. So we're going to tackle this in 3 big chunks. Part A is this framing we're doing now. Then Part B, ARM, which means we have to talk about that scary embryology.
We do.
Part C will be RDS, pure physiology. And Part D, ROP, the oxygen paradox. And then we'll wrap it all up with integration and, most importantly, the exam traps.
Let's do it.
Let's start with Part B, anorectal malformations, or ARM. This shows up all the time. Sometimes it's a long question like anesthetic management of a neonate with T-thief and associated anomalies, where ARM is the associated anomaly. Sometimes it's a specific short note.
It is. And to start, you need a solid definition. If I'm the external examiner and I ask you in a Viva, what is an anorectal malformation? And you hesitate or just say no anus, you bleed marks immediately.
Okay, so it's a spectrum of congenital defects resulting from the failure of the rectum to descend through the external sphincter complex.
Good. Spectrum is the operative word. It can be as simple as a membrane covering the anus or as complex as a persistent cloaca where the rectum, vagina, and urethra all share one channel.
Wow.
But to really impress the examiner, you need to talk about the embryology. Why does this happen?
This is where I always get stuck. The diagrams in the book look like alien biology.
Let's simplify it. Think of it this way. Go back to week 4 of intrauterine life. The embryo has a structure called the cloaca.
Okay.
Now, cloaca is Latin for sewer. In birds and reptiles, it's the common chamber for everything: poop, pee, reproduction. In the human embryo, we start with the cloaca too. It's the common chamber for the hindgut, the future digestive tract, and the allantois, the future urogenital tract. Everything is dumping into this one chamber.
So at this early stage, we are basically birds.
Effectively, yes. for a moment. But we aren't meant to stay that way. Between weeks 4 and 7, a structure called the urorectal septum descends. Think of it like a curtain coming down to the ceiling to partition a room.
A curtain.
It descends and separates the anterior urogenital sinus, which becomes the bladder and urethra, from the posterior anorectal canal.
So the curtain comes down and splits the room. Anterior is pee, posterior is poop.
Precisely. Now imagine that curtain stops halfway down, or it deviates to the back. What happens?
You would still have a connection, a hole between the rooms, a fistula.
Exactly. That is why high RMs so often have rectourethral or rectovesical fistulas. The rectum is still connected to the urinary tract because that wall, that septum, it didn't finish building.
I see.
But there is another critical fusion point. The upper anal canal comes from the endoderm, deep inside the body. The lower anal canal, or the proctodium, comes from the ectoderm, the skin folding inwards.
So you have a tunnel digging down from the inside and another tunnel digging up from the outside.
And they are supposed to meet at the pectinate line. If that membrane between them, the anal membrane, doesn't rupture, you get an imperforate anus. If the urorectal septum deviates, you get stenosis, or fistulas. Mentioning the urorectal septum and the cloacal membrane in your theory paper tells the examiner you understand the origin of the defect. It secures those extra distinction marks.
That makes so much more sense. Now, how does this embryology translate to the classification? I know we used to use wing spread, but now I hear Krickenbeck is the standard.
For the purpose of the exam, keep it simple but accurate. The examiners just want to know if you can distinguish between a low ARM and a high ARM. This distinction dictates the surgical approach, and for us, the anesthetic risk.
So let's define them. Low ARM.
Low means the rectum has successfully descended through the sphincter complex, specifically the levator antemuscle.
It passed the pelvic floor.
It has passed the pelvic floor. It's just malpositioned. Maybe there's a perineal fistula, or the anus is a little too far forward.
And the surgery for this is usually simpler?
Usually a perineal procedure, an anoplasty. It can often be done in the lithotomy position. It's less invasive.
And higher.
High means the rectum ends above the levator antemuscle complex. It hasn't punched through the pelvic floor. And as we just discussed, because the separation failed high up, it almost always involves a fistula to the bladder or urethra.
Right, because the curtain didn't come all the way down.
Exactly. And you can't fix that from the bottom initially.
No, of course not.
No. If you try to dig blindly from the bottom, you'll destroy all the nerves and sphincter muscles. These babies need a staged approach. Stage 1 is a colostomy.
To divert the stool.
Divert the stool, decompress the bowel. Then, months later, stage 2 is the big surgery, the PSRP, or posterior sagittal anorectoplasty.
The anesthetic relevance here seems huge. A high ARM means you're preparing for a major abdominal surgery later on?
That's right. And high RMs have a much, much higher incidence of associated anomalies. This brings us to the biggest exam trap of all. If you see a baby with an imperforate anus, what is the first acronym that should pop into your head?
VATER or VACTERL.
VACTERL. Let's break it down because in a long case, ignoring this is an absolute fail. You cannot anesthetize an ARM patient without ruling these out. What does V stand for?
Vertebral defects. Hemivertebrae? Sacral agenesis.
Anesthetic implication.
Difficult neuraxial block. If I'm planning a caudal epidural for pain relief and the sacrum is missing or malformed, that's a no-go.
Precisely. Also, spinal instability, be careful during positioning. Okay, A is for anal atresia, which we were discussing. C?
Cardiac. VSD, tetralgia fallit.
This is huge. Approximately 50% of ARM patients have associated anomalies, and cardiac are among the most common.
You must have an echo
before you induce.
Mandatory.
Mandatory. If there's a VSD, you have a left to right shunt. If there's a tetralogy, you have a right to left shunt. Your induction goals change completely.
Right. With a VSD, I want to avoid dropping systemic vascular resistance too much because that would worsen the left to right shunt.
Correct. But even more importantly, you need to know if the child is in failure. Pulmonary overcirculation from a large VSD can lead to congestive heart failure. You don't want to fluid overload this kid. Okay, TE.
Tracheoesophageal fistula.
This is the airway nightmare. Risk of aspiration. Difficulty with ventilation because air goes straight into the stomach instead of the lungs. If you have an ARM and a TEV, you have a baby who cannot eat and cannot poop.
That is a terrible combination.
It's one of the most challenging neonatal scenarios.
And renal anomalies, renal agenesis, hypospadias.
Renal affects your fluid management and your drug clearance. If they have only one functioning kidney, you need to be very precise with nephrotoxic drugs and your fluid balance. And L is limb defects like radial aplasia.
Which might make arterial line placement tricky if the radial artery is absent.
You see, the Vader trap isn't just a list of names. It's a checklist for your preoperative assessment. In the exam, if you say, I would perform a pre-anesthetic check, you get 1 point. If you say, I would specifically look for a murmur to rule out VSD, check the spine for sacral dimples to rule out vertebral defects, and request a renal ultrasound, you get full marks.
That is such actionable advice. Okay, let's talk about the surgery itself. We've assessed the baby. We've ruled out or planned for the VACTERL anomalies. Now we're in the OT. What are the big anesthetic goals for an error repair?
Temperature control, fluid balance, and airway security. These are the 3 pillars.
For induction, do we treat them as a full stomach?
Always. If they have an anorectal malformation, they have a bowel obstruction, period. Even if they have a fistula, it's rarely adequate for decompression. They are bloated. They might be vomiting. So rapid sequence induction, RSI, is the classic teaching.
But in a neonate, a true RSI can be dangerous if you lose the airway.
It can be. So we modify it. You gently suction the stomach first with an OG tube. Pre-oxygenate well. You might use propofol or thiopental, but be ready with suxamethonium or rocuronium. But here's the nuance. If there's an associated TT, positive pressure ventilation is your enemy. You blow up the stomach.
Right. So you'd want to keep them breathing spontaneously if possible, or intubate without bagging.
Ideally, yes.
Yeah.
But for a pure arm repair without T, you secure the airway with an endotracheal tube. An LMA is generally not a good idea for a bowel obstruction case.
And positioning is another big one. For the PR procedure, they are prone, right?
Yeah.
In that jackknife position.
Jackknife prone. Their hips are flexed, bum in the air.
That sounds terrifying for managing a neonate's airway.
It has very specific risks. First, the abdomen is compressed. This pushes the diaphragm up, reducing functional residual capacity, or FRC, and making ventilation harder.
So you need to use rolls?
You must use rolls under the chest and pelvis to ensure the abdomen hangs free. That allows the chest to expand. Second, the airway itself. The tube can kink. The face can get compressed, causing pressure sores. You have to check the eyes and nose meticulously after positioning.
And monitoring, obviously SpO2 and ECG. But temperature?
Temperature is absolutely critical. These babies lose heat so fast, they have a huge surface area to body weight ratio. The bowel might be exposed. You need forced air warmers, warm fluids, increase the ambient room temperature. And here's a Viva trick. Where do you put the temperature probe?
Not in the rectum.
Exactly. You would be surprised how many people say rectal probe out of habit. Esophageal or axillary.
And post-op pain. You mentioned caudal before.
Caudal epidural is the gold standard for these perineal procedures. It provides excellent analgesia and reduces the need for systemic opioids, which, as you know, can cause apnea in neonates.
But again, check the spine first.
Always. If there is a sacral agenesis or a tethered cord, which is common in Vader, you absolutely cannot do a caudal.
So then you're back to IV paracetamol and carefully titrated fentanyl or morphine.
Correct. And remember, these babies might be ex-prematures. If they are less than 60 weeks post-conceptual age, they are at high risk for post-op apnea. They need NICU monitoring, not a standard ward bed.
Okay, that covers ARM. It's not just a surgical fix, it's a whole systemic puzzle. Let's move to the second part of our trinity. Respiratory distress syndrome, RDS. This feels like the bread and butter of neonatology, but as anesthesiologists, we see it when these babies come for surgery later on.
We do. RDS, or hyaline membrane disease as it used to be called, is the single most common cause of respiratory failure in preterm infants. The exam question here is almost always about the pathophysiology.
It all comes down to surfactant, right?
It does. But dig deeper. Why do we need surfactant?
To reduce surface tension in the alveoli.
Yes. And what does that mean practically? Let's look at the law of Laplace.
Right.
P equals 2T over R.
Okay. Pressure equals 2 times surface tension divided by the radius.
Right. So if surface tension T is high and the radius R is small, like in a tiny preterm alveolus, the pressure required to keep that alveolus open is huge.
It's math.
Exactly. Without surfactant, T is high. The alveoli just collapse at the end of expiration. This is atelectasis. Now, you have a baby who has to generate enormous negative pressure just to open their lungs with every single breath. It's like trying to blow up a brand new sticky balloon every 2 seconds. They get exhausted.
And that leads to the cycle of doom you mentioned in the notes.
The cycle of doom. Atelectasis leads to VQ mismatch. You have blood flowing past collapsed alveoli so it doesn't get oxygenated. That's a shunt.
Right, which causes hypoxia and acidosis.
And the acidosis causes pulmonary vasoconstriction.
Which worsens the VQ mismatch even more.
And it damages the endothelium. You get plasma leaking into the alveoli. The fibrinogen in the plasma turns to fibrin that mixes with necrotic cells to form the hyaline membrane. It's this glassy, eosinophilic layer that lines the alveoli and blocks gas exchange even further.
It's just a vicious downward spiral. And the risk factors. Obviously, prematurity is number one.
Prematurity, of course. Surfactant production starts around 24 weeks, but really isn't sufficient until 35 weeks. But here is the examiner's favorite risk factor to ask about: maternal diabetes.
Why does maternal diabetes cause RDS? I always thought stress accelerated lung maturity.
Chronic stress does. Things like maternal hypertension or IUGR
Yeah.
that releases cortisol, which stimulates surfactant production. But in a diabetic mother, the fetus is hyperglycemic, so the fetus produces high levels of its own insulin.
And insulin is an antagonist to cortisol.
Bingo. Insulin actively antagonizes the cortisol-induced stimulation of surfactant synthesis. So you have a macrosomic baby, they look big and chubby and healthy, but they have functionally immature lungs. It's a classic trap.
That is fascinating. So the high insulin blocks the lung maturation signal. What about a C-section delivery?
The stress of labor is actually beneficial for the lungs. That stress releases catecholamines and steroids in the fetus, which help squeeze fluid out of the lungs and stimulate surfactant. A planned C-section without labor denies the baby that hormonal boost, so they are at a slightly higher risk for RDS and TTM.
Diagnosis. Clinically, it's that grunting sound.
Grunting is physiological PEEP. The baby is exhaling against a partially closed glottis to try and keep the alveoli open. You'll also see nasal flaring, intercostal retractions. And on X-ray, you see the classic ground glass appearance with air bronchograms.
And the management is, well, prevention is antenatal steroids.
Betamethasone to the mother, preferably 48 hours before delivery. It reduces RDS mortality by half. It's a miracle drug. But if they have RDS, we give surfactant replacement.
Directly into the trachea.
Intratracheal installation of bovine or porcine surfactant. It's magic. You give it, and you can literally see the compliance improve on the ventilator almost instantly.
From an anesthetic perspective, if I have to anesthetize a neonate with a history of RDS, say for a PDA ligation or bowel surgery, what is my ventilation strategy?
Gentle. You have to be so gentle. These lungs are stiff, but they're incredibly fragile. You must use a lung protective strategy.
So, low tidal volumes.
4 to 6 millimeters per kilo. Do not blow them up with 10 or 12 millimeters per kilo like you might an adult. You'll cause VALD trauma.
And PEEP.
PEEP is crucial. You have to prevent that end expiratory alveolar collapse. But you have to be careful. Too much PEEP can reduce venous return and cause hypotension. It's a delicate balance.
And what about permissive hypercapnia?
We tolerate higher CO2 levels, say 50 to 60 millimeters of mercury, as long as the pH is above about 7.25. We prefer a slightly acidic pH over destroying the lungs with high pressures, which is barotrauma, or high volumes volutrauma.
Okay, so gentle ventilation, use PEEP, and don't panic about the CO2. Now let's transition to the third member of the Trinity, the one that keeps me up at night because it involves blindness. Retinopathy of Prematurity, ROP.
ROP is a disease of medical progress. We save premature babies with oxygen, but in the early days, we blinded them. It's a tragic irony.
What is the mechanism? I know it involves oxygen, but it's not just oxygen kills the eye, is it? It's more complex.
No, it's biphasic. This is the exam gold right here.
Yeah.
Phase 1 is vaso-cessation. When a baby is born premature, the retina is not fully vascularized. The vessels haven't reached the periphery yet. If we then blast this baby with high oxygen, say 100% FiO2 for a prolonged period, the retina thinks, oh, I have plenty of oxygen. I don't need to grow any more blood vessels.
So it downregulates VEGF.
Exactly. Vascular endothelial growth factor, VEGF, drops. And retinal vessel growth just stops dead in its tracks. That's phase 1.
Okay, and phase 2?
Phase 2 happens later as the baby grows.
Yeah.
The retina becomes more metabolically active. It needs more oxygen. But remember, the vessels stopped growing. So now the peripheral retina becomes profoundly hypoxic.
Relative hypoxia.
Yes. And the hypoxic retina screams for help. It releases a massive, uncontrolled surge of VEGF. This causes rampant, disorganized neovascularization. These new vessels are leaky and fragile. They bleed, they form scar tissue, and that scar tissue contracts.
Pulling the retina off the back of the eye.
Retinal detachment.
Blindness.
So the damage is set up by the initial hyperoxia, but it's executed by the subsequent hypoxia and the VEGF surge.
Precisely. It's the fluctuation in the extremes that cause the damage. This leads directly to the anesthetic management. When I'm anesthetizing a preterm baby, say for an inguinal hernia repair, how do I manage their oxygen?
It's the Goldilocks principle. Too little oxygen, you get brain damage or death. Too much, you get ROP or bronchopulmonary dysplasia, BPD.
So what are the targets?
Current guidelines generally suggest maintaining SpO2 between 91% and 95%. Some centers might say 88 to 92% for the extremely low birth weight infants. The key for the exam is to say, I will avoid 100% oxygen unless it is absolutely necessary for resuscitation, and I will use an air oxygen blender.
That's a crucial piece of equipment, the blender.
Yes. If you put a neonate on a standard anesthesia machine and just turn on the oxygen flow meter, you might be delivering 100% O2. You need to be able to dial in the FiO2 precisely. Aim for the lowest FiO2 that maintains that saturation target.
Okay, but what if the baby is desaturating during induction? The SpO2 drops to 80%. Do I still withhold oxygen?
No. This is Viva trap number 1. If the baby's blue and the heart rate is dropping, you give 100% oxygen. You save the life first.
Okay.
ROP is caused by chronic exposure and long-term fluctuations. A few minutes of 100% O2 to save a life is absolutely acceptable and necessary. But as soon as they stabilize, you wean it down immediately.
That's a huge relief. I was worried I'd have to let a baby stay blue to save their eyes.
Never. Life over limb, life over eyes, always. But good anesthesia means you don't let them get blue in the first place, and you don't overdose the oxygen. It's a tightrope.
Let's talk about ROP surgery itself. Sometimes we have to anesthetize these babies for laser photocoagulation or cryotherapy.
Yes, these are very high-risk procedures. The baby is usually tiny, ex-premature, often with bad lungs from DPD. And the surgeon is working on the eye with a laser.
So what's the airway plan?
The surgeon needs completely still head. If the baby moves even a millimeter during the laser, you can burn the wrong part of the retina. So usually this means intubation and paralysis, or a very deep LMA anesthetic. The dilemma is that anesthesia itself causes apnea, and these babies are already prone to apnea.
And oculocardiac reflex.
Very, very high risk. The surgeon is pressing on the globe. You need to be staring at the ECG. If you see bradycardia, you tell the surgeon to stop. Stop. Let go. Have atropine drawn up and ready.
Okay, let's try to integrate all of this. Part E. The role of the anesthesiologist. It really feels like we are the guardians of the entire physiology.
We are. You are managing a patient who likely has an A-arm, is recovering from RDS, and is at risk for ROP. It's all connected.
For example, if I have a baby with A-arm, I'm worried about fluid balance because of potential renal anomalies from Vater. But I'm also worried about lung compliance because of a history of RDS, and I'm watching the oxygen like a hawk because of the risk of ROP.
Exactly. It's a constant balancing act. You have to keep the baby deep enough so they don't move for the surgeon, warm enough to clot blood because hypothermia causes coagulopathy, and ventilated gently enough to save the lungs, all at the same time.
Let's just touch on that oxygen therapy again, the double-edged sword. You mentioned oxidative stress.
Oxygen is a drug. It has toxicity. It generates free radicals that damage not just the eye, causing ROP, but also the lung, contributing to BPD and the brain. In the exam, if you're asked about oxygen, you should explicitly state, oxygen is a drug with potential toxicity. I will titrate it to effect using an air oxygen blender to achieve target saturations. That shows maturity and understanding.
Okay, part F, exam integration. Let's do some of those comparison tables you mentioned. Audio style, RDS versus transient tachypnea of the newborn, or TTN. How do I tell them apart in a Viva?
History and volume.
It's a premature baby. You'll see low lung volumes on the X-ray, the classic ground glass appearance. And the cause is surfactant deficiency. TTN. It's usually a term or near-term baby, often delivered by C-section. You'll see normal or even increased lung volumes on X-ray, with perherular streaking, which is fluid. The cause is delayed resorption of fetal lump fluid.
And the management is totally different.
Completely. RDS needs surfactant and often prolonged ventilation. TTN just needs supportive care, maybe some CPAP, and it usually resolves in 24 to 48 hours.
Perfect. Okay, next one. Gastroschisis versus omphalocele.
The sac, that's the key difference.
Has a peritoneal sac covering the bowel. The defect is at the umbilicus. It's highly associated with chromosomal anomalies like the trisomies and cardiac defects. Think Beckwith-Wiedemann syndrome, big tongue, hypoglycemia.
Got it. And gastroschisis.
Gastroschisis, no sac. The bowel is floating freely in amniotic fluid, so it comes out looking thick and angry from a chemical peritonitis. The defect is usually to the right of the umbilicus. You have huge heat loss and fluid loss from the exposed bowel, but it's less associated with other major congenital anomalies.
So for anesthesia, gastroschisis needs massive fluids and temperature management. Omphalocele needs a mandatory cardiac workup.
You've got it. That is high yield. Now let's hit those Viva traps again. Trap number 1, the nitrous oxide trap. Never, ever use nitrous oxide in a neonate with a bowel obstruction like ARM or a congenital diaphragmatic hernia, CDH.
Because it expands gas-filled spaces.
Exactly. Nitrous diffuses into gas-filled spaces faster than nitrogen can leave, so it expands them. In CDH, you compress the already tiny lungs. In ARM, you distend the bowel so much the surgeon can't get it back in. Just ban N2O from your neonatal list. It's safer.
Okay. Trap 2, ignoring the Vater association.
We covered this, but specifically, if you have an esophageal atresia case and you don't ask about the heart before you start, you will fail the station. The association is just too strong.
And trap 3, treating ROP as purely an ophthalmic issue.
ROP is a sign of systemic instability. If a baby has severe ROP, they likely have severe lung disease, BPD. They likely had episodes of sepsis. They likely had intraventricular hemorrhages. You have to treat the whole baby, not just the eye. Expect a difficult airway and very poor physiological reserve.
Sir, this has been incredibly helpful. I feel like I finally have a framework now. I'm not just memorizing lists of facts.
Structure is everything. In the exam, safety comes first. Start every answer with your safety checks. I would assess the airway. I would check the glucose. I would maintain normothermia.
Remember the key take-homes.
Think Vater and embryology,
Right.
RDS. Think surfactant and gentle ventilation, ROP. Think oxygen toxicity and titration.
And for the final provocative thought, something to leave us with.
We talk about all these sophisticated technologies, surfactant, high-frequency ventilation, laser surgery, but the single most effective intervention for neonatal outcomes often happens before the baby's even born.
Antenatal steroids. Antenatal steroids. It's a reminder that anesthesia doesn't start at induction. It starts with the maternal history. And also, think about the long-term neurodevelopmental outcome. We are getting better and better at keeping these incredibly premature babies alive, but are anesthetics affecting their developing brains? That is the next frontier of our specialty.
Something to mull over for sure. Thank you, sir. This was invaluable. And to everyone listening, good luck with your Gujarat University exams. You have the knowledge, structure it logically, and you will pass.
Good luck. Go get those marks.